Welcome everyone. Welcome everyone. We are going to go ahead and get started. This is the last Friday of the month. We are so excited about our community of practice workshop today for this month. So as we get started, if you would just go ahead and drop your name and where you're joining us from, and what is one thing that you are most looking forward to this summer. We are recording this session, and you will be able to see it and share from our POCC Partners YouTube channel, as well as we have the live transcript going, so you can hit the closed caption. If you are new to POCC Partners, we just want to share a little bit about who we are and what it is that we do. We believe in a health system being transformed. We're looking towards and working towards one that works with people and through communities as a partner in their well-being. We're doing that by being a catalyst for system transformation, looking to center the inclusive human experience of health. You can see our values here as well, where we believe in and value equity, inclusion, diversity, collaboration, and we're solution focused. Now, we all know that healthcare is complex. It's a system that is difficult to navigate and can be even more difficult to change. And we're here to take on that charge. Through POCC Partners, we know the importance of having an open space for patients and family caregivers to be able to drive the change within those systems. And one of the ways that we do that in the space that we create is through our PFA network. The PFA network was built by patients and families for patients and families. The PFA network is a space that is filled with impactful people, stories, and insights. And we know that by incorporating people with lived experience into the systems, into the policies, is a way that we can enact change. Uh-oh, my fingers are going faster than they should be. So I am so excited to bring this session to you all today. We'll be diving into the pilot initiative to support successful transitions from incarcerations presented by Main Care Services personnel. We have a dynamic team here with us today. We have Loretta Dutil, who is the Operations Manager, System Reform Unit. We have Callie Bushy, who is the Opioid Health, Home, and Behavioral Health Home Program Coordinator. Lisa Tuttle, with the Justice Initiatives Project Manager. And Dr. Courtney Pladsen, the Maine Medicaid Medical Director. And with that, I will turn it over to Loretta.
Well, good afternoon, everyone. Like Naomi mentioned, my name is Loretta Dutil. I'm the operations manager for the Delivery System Reform Unit here at Maine Care Services, which is also known as the State of Maine Medicaid. And I'm here with my wonderful colleagues today to talk to you a little bit about the work that we've been doing with engaging community members, patients, and other stakeholders and impacted individuals as part of our work around the post-incarceration incentive payment pilot and other justice-related initiatives that we've been working on. So very happy to be with you all this afternoon to talk to you about the work that we were doing here in Maine. So this is an overview of what we will be discussing. So just giving you a brief overview of sort of what the landscape looks like as far as Maine Care's justice initiatives. Talk a little bit about the spectrum of community engagement framework, which is kind of how we are framing our work today. So we will keep referencing that as we kind of go through the discussion today. And then we'll also talk about the, kind of sort of where we've been in terms of the post-incarceration incentive payment and justice initiative community engagement, and where we currently are, and also where we're planning on going in the future. And then, of course, we will take any questions that you have. So with this slide, I can either go over it or I think I'll actually have Courtney review these two slides because she is actually a project sponsor for the Justice Initiatives, and she's done some amazing work on all the different initiatives at varying levels. And so I'd really like her to kind of talk a little bit about the Justice Initiatives overall and kind of some of the more recent work that has been happening around the Justice Initiative. So I will turn it over to Courtney.
Thanks, Loretta. So there's amazing work that the Foundation to the Justice Initiatives that Callie and Loretta have laid and have been working on for many years. And then thankfully, because of that, through the post-incarceration incentive payment pilot, they put us in an amazing position to really work on these other initiatives. So the first piece, the pilot project, is really to help provide incentive to providers to better partner with jails and prisons to try to decrease the length of time from release to entering into care. And the providers are providing behavioral health services, primary care, case management. And if they provide those services within 2 business days of release, they automatically get an additional payment. So that's the payment pilot. And really part of that is not only to incentivize this timely care, but really also to help us understand who are the top providers, who is doing this work, who is doing this well, and understand how and why they're doing it well. And then number 2 is the Consolidated Appropriations Act. So Congress in the end of 23 passed the Consolidated Appropriations Act, which included a provision requiring all state Medicaid programs to cover services for juveniles who are incarcerated 30 days prior to release, to provide case management and certain behavioral and physical health screenings to improve the reentry period. So we're working on implementing this now in 2025. But thankfully, to some of that work that the work that Callie and Loretta did, that put us in a much better position than most states. So we're just really grateful for that. And then now there was a law that passed in Maine requiring MaineCare to apply for 1115 reentry waiver. And here the goals of the waiver are here, but really what this is we apply to the federal government for a waiver. Right now you cannot use Medicaid. There's an Inmate Exclusion Act which prohibits us from using Medicaid funding to provide services for people who are incarcerated. An 1115 reentry waiver would allow us to provide services pre-release for this population, again with the goal of helping to improve the healthcare continuum, improve the care coordination upon release. So we're starting with the pilot, getting to know the provider organizations, incentivizing this care. The youth initiatives are really focused on this particular subset. We're working on implementing that now. 1115 waiver will be implemented in 2027. So we're working on finalizing our application to CMS and hope to submit in the next few weeks. And then we will then work for the next 2 years on developing the implementation plan, the details of this, with the goal of launching that in 2027. 1115 waivers really will be a very broad, big effort. These others are really incremental steps to working towards this 1115 waiver, which is really going to be transformational for our entire criminal legal system. So with that, here's where we are. We started with the pilot, we're implementing the CAA, and we've been working on the application for 1115 waiver, and then we'll implement in 2027. I'm going to turn it back over to Callie to talk a little bit about the spectrum of community engagement and ownership and kind of where we are, where we were when we started these initiatives with the pilot, and where we're really hoping to move. I just want to credit HE for this tool, which we've really been thinking about and processing as a team of how do we really meaningfully do community engagement and engage with people with experience. We'll turn it back over to you, Loretta.
Great. Thank you so much, Courtney. Yes, so we will be referencing this framework throughout our presentation. And as Courtney mentioned, this was something that was shared with us through our Advancing Health Equity collaborative work. And it's really just a great way to look at the different levels of community engagement starting from not involving the community in the work that we're doing, and moving all the way towards deferring certain decisions to community partners. I think that as we kind of go through our presentation, you will notice that our thinking sort of had evolved throughout this process, and it's always interesting to look back to see where we started, how it evolved over time, and sort of the direction that we're going in the future. So you'll see that as we're talking through the different pieces, and we will point it out too, that we kind of move across this continuum going up and down. But but as time goes on, it starts to become more intentional. So I just wanted to kind of highlight that as part of this continuum. Next slide, please. Great. And so here, this is just an overview of where we started with the post-incarceration incentive payment pilot. The planning of the pilot started back in 2019, and it really started as part of the Advancing Health Equity Collaborative. The Advancing Health Equity Collaborative, for those who are not aware, is a team-based approach to advancing health equity, and it currently consists of, I think, about 12 or so state teams. And these teams consist of Medicaid agencies, Medicaid health plans, healthcare delivery organizations, really with the goal of designing healthcare delivery system reform with the goal of reducing health disparities. And so the collaborative also provides technical assistance throughout the process to help with design and implementation of this work. So here, our original group consisted of organizations that spanned both behavioral and physical health care organizations. And I did just want to note that Maine is a fee-for-service state. So what that means is that we typically work directly with organizations with our communities, as opposed to working through a managed care organization. So here, our original focus was on members with a history of incarceration. We know that these members have high risk of overdose and disconnection from care as compared to their peers, without history of incarceration. And so our goal really was to create an incentive program that would target timely follow-up after care and connecting to care to address their immediate needs after release. Next slide, please. So when we started our development of the pilot, one of the first things that we wanted to do was engage individuals that would be most impacted by our work. So on our team, we had a licensed counselor, and she was a member of our collaborative team, and she already had connections with the local jail and other groups that had individuals who had a history of incarceration. And so we were able to utilize some of that connection in order to have focus groups within the jail. So these are some of the primary themes that we took out of those focus groups that helped inform our pilot. So with that work, one of the key takeaways that we had was that there really was a wide range of services that was needed upon release. It really was individually based, which is kind of why one of the reasons why we focused our pilot was on a wide range of services, and we didn't just limit it to a few. Some of the lessons learned we have that are listed here is that we want to make sure in future focus groups that we kind of lowered the power dynamics. So our goal was to be more intentional as we looked forward into additional focus groups, to find ways to reduce the amount of power dynamics as it goes, as it related to the conversations that we had within those focus groups. And then the other thing was that we noticed that it's important to, as we are moving through the different processes of design, implementation, that it's also important to go back to those conversations and share with them where we're at with the process. So that way we understand if there's any additional feedback that'll be helpful for us as we move forward with those processes.
So my name is Callie Bushy, and I'm going to talk a little bit about our post-incarceration incentive payment. So the purpose of the payment was really to incentivize our main care providers to connect with individuals being released from incarceration within 2 calendar days. How we did this is we pulled like a baseline report to kind of know who was kind of meeting that requirements. And then in March of 2024 was our first incentive payment. Our first incentive payment, we did have over 100 claims of showing that a member was connected within 2 business days from being released from incarceration. And then we did this every quarter. So every quarter we kind of saw a slight increase, not as much as we were hoping, but did see some increases. And then our last incentive payment pilot payment will go out in June, which is next month, and that will be the last one that we have connected to the incentive payment. From there, it's really easy. Providers didn't have to do a lot of work on their end, except really try to connect and connecting members to services when they're being released from incarceration. If there was a claim that was submitted showing that they provided a service to that member, they got an incentive payment. So it was great. There wasn't much work on their end. With reporting data back to main care, we were just able to pull that information and then give them the incentive payment. We included almost all of our services, I will say. Some things that we didn't include was emergency room visits. We didn't include transportation on those, but things like connecting with a dental office, connecting with a PCP, being able to go to a behavioral health provider for either mental health or substance use treatment, things like that. We saw a lot. We saw a lot of people who were in a residential facility for substance use treatment. So it was really great to kind of see the mixture of providers that were coming into the picture of receiving this incentive pilot. Our payment was $236.77 per eligible claim. So if a member had 2 claims for 2 different providers, that was great. Both providers got it. But if they had 2 claims for the same provider in the same day, which normally are not allowed to happen, or within that first 2 days, they got paid once for it. People who have been released from incarceration face lots of barriers with healthcare, including cost, stigma, long wait times. So this was really to help encourage our providers to connect with the jails and prisons and the personnel in there to really build that relationship. So when people are being released, there's not gaps in their care, that they can get right into services and get the support that they need. Next slide, please. So by doing this incentive pilot, we were able to develop our high providers that have a lot of claims and were able to connect with members and had individual meetings with these providers that met the incentive payment requirements. And when we met with them, we really talked about a lot of information with them. We created a survey to ask them, but we wanted to have it on SurveyMonkey so we can kind of pull all this information together. So every time we went with a provider, we typed it in there. So we had the information to look back at. They said that some of them had really strong partnership with jail, prisons, and treatment court. They established a referral process, so it was easy for that transition for that individual coming out of incarceration. They supported initial transition needs of the residents, made sure that they had a phone, transportation, toiletry items, offered same-day access to care, had previous connections and contact with the person, peer, a patient navigator prior to incarceration. So just to kind of go back on that, some of our providers work directly in the jails and prisons, with the members, the individuals that are residents at the time, and they provide services with them. So Courtney will talk a little bit more about the work that they did with reaching out to the prisons and jails, but some of our providers already had those connections. So it was easier for them to connect with individuals when they were being released because they already had that build that relationship with them. Some challenges were unplanned releases. So we don't always know of a release date when someone's, it could be, they say within the next week, but it could be Monday, it could be Friday. So that's sometimes hard to juggle. Transportation and housing is has been a challenge. Delays in main care eligibility. So sometimes the jails and prisons are reporting that back to main care when someone's being released so they can switch their main care back to full main care. But if not, it would be the member's responsibility. So it was a delay to let them know that their address changed and that they are back in the community. So they face those challenges. Space and technology within the jails and prisons, it helped. It's limited in some areas depending on the county and where the jail and prison is. So it prevented connecting prior to release. Priority shifting once released and multiple organizations involved. So those were some of the challenges that providers faced. Next slide, please. And so you saw this already through the beginning of the presentation, but this really just shows where we are. We're still consulting and getting information, but we're really collaborating with the community, the partners in the community, our providers, people that have experience with incarceration. Like that work is still going on and it will continue to go on because we really want to make this next step reasonable, and we want to hear the experience that people are facing and the challenges and the successes that they are, so we can share those and kind of help them along this way, because our real big focus is really connecting people when they're being released from incarceration, because it's important that they don't have that gap in services and that they don't end up back in jail and prison either. Loretta, do you want to add anything else to that before?
Yeah, I mean, I'll just add when we originally started with the focus group that I resonate with more of the consult area, because we did think of, you know, getting that input feedback to help support the work that we're doing. But as I mentioned earlier, I feel like that we could have been more intentional about how we went about creating those or connecting with the focus groups.
Thank you. Now I'm going to talk about kind of where we are now. Oh, sorry. I think we changed it up a little bit, so I apologize. So the community engagement and purpose of the goals. So really, we want to work on building those working relationships with diverse partnerships in various settings. It was very important for us to kind of reach out. So we started with the providers that we knew that we work with on a daily basis. But from that, we started presenting at different alliance groups. We started presenting to individuals that have been incarcerated prior. We worked with the different jails and stuff, because our purpose is really to actively listen and hear from individuals, family, and communities with lived experience, because they're the ones that are experience how it feels to be released and not have these services and connections. We wanted to meet with providers to really better understand where the gaps are and where we can help try to build that relationship with the jails and prisons. And then we want to meet with each jail and prison too. And Courtney will talk about a little bit more about this too, and how it was important for us to understand where their barriers are coming from and how we could help as a state to improve this easier access to individuals being released. So I think this is my last slide, but the focus group. So I just wanted to talk about like where we are now and what our purpose is. So we went to Chicago back a few months ago. It's probably longer than that, but we really collaborated and worked with the Advancing Health Equity team to understand how we could address power dynamics. We There was an individual that was really kind to meet with us and go through our survey that we wanted to ask residents that are currently incarcerated, and talked about the language that we were using and how we could change our language to really help um, support them better and to not stigmatize against different things, and to make sure like that they weren't feeling overwhelmed with those questions. We made sure that we contracted with a community-based organizations to have peers who could conduct these focus groups. We thought it would be very overwhelming to have someone from the state or multiple people from the state going in and asking these questions. We thought an individual would feel more comfortable with peer-to-peer conversation. And then through that partnership, we were able to compensate individuals to participate. So we can't compensate directly, but we were able to contract with someone so they could compensate the individuals to be able to show that we really appreciate their time and effort and the support that they are giving to answering our questions. Our long-term goal is really to be able to engage individuals impacted by the initiative to gather valuable input. So we're going to continue meeting with stakeholders, partners in the community, individuals, and really build that solid foundation, and go back and talk to the individuals that we met with at the very beginning too, to see have they seen change? Is there anything that we can continue to assist with? And this is why it's important with the work that Courtney with the CAA and the 1115 waiver stuff is going to be able to kind of move that forward, hopefully easier in the long run. And next slide, but I think I'm handing it over to you, Courtney.
Yeah, thanks, Callie. So thank you for tracking. We started the listening sessions that our teams initially did. And then there was community engagement with providers who were providing the services to people as they're being released upon the reentry. So community engagement with people with lived experience, who have been justice impacted, engaging the staff that are providing services. And then we started really thinking, okay, we have to come up with a community engagement strategy, because the 1115 waiver is really going to change our criminal legal system. We have to do even broader engagement to understand all of these systems. And part of this is because Medicaid has never been in this space. We have never partnered with jails or prisons. We don't I'll speak from my space. I had never had a vision into carceral healthcare and what the services are being provided. And so I knew that to meaningfully do this work, our team had to understand these systems and really approach this with a lot of humility, as saying, we're new, we need to better understand and know that we're not experts in this space. So this is a lot on this slide, but really just to give just a visualization of the thoughtfulness that went into thinking about who are all the different individuals and organizations that we need to engage in. So we have been working in developing a strong partnership with our Department of Corrections for the first time. And I meet with the Deputy Commissioner every 2 weeks. We toured every jail and prison in the state of Maine. We met with every carceral healthcare provider in the state, so anyone who provides services within these facilities. We worked to identify of all the different teams within the Department of Health and Human Services. There are many organizations and programs that intersect with our carceral systems, and so we met with people within the department. We mapped out who are providing these services in the community, who's providing services, who's doing in-reach, who partners with jails to provide services upon reentry, and we mapped those out. And then we specifically were thinking of and found out that there are various organizations that are made up of people who have lived experience, who've been justice impacted, like the Maine Prisoner Advocacy Coalition. We met with them. We went to multiple meetings of theirs to explain the initiatives and to talk about direction and having their input in this work. We learned that each jail has a board of visitors, which are made of people from the community that help hold that jail accountable. The Wabanaki Nations, our indigenous populations within the state, are disproportionately incarcerated. It's really important for us to be able to meet and engage with all the 5 different nations within our state to understand their unique needs and intersections in these systems. understand the unique needs of veterans and LGBTQIA plus populations. We met with various organizations representing these populations. So it's a lot. I just want to recognize that. But this is really the work of this waiver is many, many years where we will implement in 27, and then it's a 5-year waiver going to 2032. And we felt it's really important for us to do this community engagement as foundational to this work. And just to get a sense, we are a very large, geographically wide, large state, even though we have a very small population. So we went to all corners of the state. This is just representing all of our jails and prisons. So as we are doing this work, we're trying to go from just the consult and moving down the road to really focus on involving, collaborating, and moving towards deferring to. And I'm going to talk about how we're operationalizing some of this. So here's where we're going. So demonstrating some of the collaboration. So through that engagement, what's been really important for me is to say, okay, thanks for your input, and not just say goodbye and not go back, but instead continue to develop these relationships longitudinally. So I attend the Sheriff's Association meeting every 2 months and provide updates on this. And part of that has been, I go to their meetings, I present on a topic or strategy, I get their input, and then next meeting I say, here's what, from your input, here's the changes I've made, or here's the direction we're taking. So helping these individuals and organizations to see that what their input is actually driving the shape of this initiative, and that feels really important. So the sheriffs are really the ones that oversee our county-based jails and community corrections. So it's really important, if we're going to get buy-in, we need to meet with our sheriffs. And I'll tell you, I'm probably the last person that ever thought I'd be working with the Sheriff's Association. I went into this work with a lot of bias. In addition to my work within Medicaid, I work 1 day a week in my local healthcare for the homeless clinic, and I've been working in healthcare for the homeless health centers for over 13 years. And people experiencing homelessness are disproportionately incarcerated and often over-policed. And so I often feel very frustrated, have negative interactions with community policing. I stepped into this work, and I have family members who've been just as impacted and incarcerated. And so I went into this work with a lot of bias. But I've learned, and it's been very important, that if I want to truly have systemic change, I have to engage with all of the people that are intersecting in these spaces, not just the natural allies in this work. And so I need my advocacy organizations, the Maine Prisoner Advocacy Coalition, just as much as I need to work with the Sheriff's Association. And it's been amazing how much they have bought into this. They see the vision. They are excited about this. We've talked about the ways that this work is going to help them and to decrease recidivism, improve community safety. And one of the ways that I took something that they shared and brought back a proposal is that because Maine is so large, our counties really vary widely. We have for example, Franklin County, very small, very rural county. Their jail has 30 beds. It's tiny. And then Cumberland County, our most populous county, has over 300 beds. The resources in those facilities are wildly different. And then the resources in the community are wildly different. And so I heard loud and clear, we don't want you as the state to create a one-size-fits-all approach. It will not work. It won't be successful. And I heard that, and I went back and we worked with our team to say, how do we do this? How do we operationalize something where we say here what is required, but then really take the careful consideration of every county? So we decided to do was develop what are called community profiles, where we've taken all of our counties and basically have a 2-pager of all of the resources within the jails, in the community, who they partner with for reentry services. And through that, we now are going to say, here are the 3 things that we are requiring of all of you for the 1115 waiver. You all have to provide medication for substance use disorders. You all have to provide case management. You all have to provide medications upon release. But we're going to work with you to figure out who's the best organization to partner with to make that happen, to operationalize it. Is it your current carceral healthcare provider? Is that a community-based provider? Are they going to do that via InReach, through telehealth? So then we're setting the standard, but we're going to work with each county to design a program that works for them. The other thing we heard is that jails and prisons are exceptionally different. People move through jails very quickly. The average length of stay is 13 days. To be in a prison, you have, by definition, have to have a sentence of over 9 months, and it's a fixed release. We know that people are there who've been what's called adjudicated, and they've been sentenced. You show up in a jail, you could be gone, and you could walk in post bail and walk out the door. So the sheriffs identified jails as the emergency department of the system, and prisons are much more stable. They've already, people have been through a jail system before they go to prison. So I've heard, and now I understand, that these are very different systems, that we can't create a one-size-fits-all approach. We met and worked with the Maine Prisoner Advocacy Network, and this is that power dynamic and sharing, as Loretta shared. We developed a contract. We want to compensate them for their time and expertise. They're going to lead the listening sessions rather than us, so that it's people that they can feel comfortable with, peers who have moved, who've been themselves residents of jails and prisons. We're providing, through the funding we're giving to the Maine Prisoner Advocacy Network, they're going to provide stipends to people for their time and expertise. And then lastly, we're going to work with the Maine Reentry Network. We're developing a contract with them now, and they're going to help stand up a community advisory board. We have funding. We're using our CAA planning grant to develop a community advisory board for the next, and we have funding for the next 4 years. And we're going to start our first in the state, a health and reentry one-day conference. So we realized we don't want this to be state-led. We want this to partner with people with lived experience. We want to develop a community advisory board to really work with them to make sure that their voices are directly influencing the shape of the initiative and what this will look like to have maximum benefit. We know that if I personally design a system, I have many gaps. I'm only looking at it through one lens. And so we want the people closest to the problems to be able to really drive the solutions. So we're really excited about these partnerships. And this is really what we're working towards. This is the goal of the waiver. We want to improve access to care. We want to reduce ER visits, reduce hospitalizations, improve the continuity of care, really improve communication, create a continuum of healthcare that hasn't existed before, reduce all-cause death, and increase investments in healthcare-related services. So I want to say that this is it feels aspirational because it is. We really want this to be transformative, and this is what we're driving towards. And what we're working towards, we want to move to, with this community advisory board, really work towards deferring to people with lived experience. We want to compensate the Maine Reentry Network for them to help lead and drive this work. For the conference, we want them to tell us how they want to shape that conference, what will be the most impactful. So we're as we learn better, we're trying to do better in this work. And that's it. I'm going to take down the slides so our team can answer questions, and we welcome them.
If you have any questions, please, you can drop it in the chat or come off mute. And
this is Dorothy. I'm off mute because,
yes,
like I said, I don't know how to use this my iPhone. But I think they did a wonderful job of presentation, as well as it's amazing to hear the groundwork. I'm part of the a patient partners academy, and they talk about this messenger, this excellent messenger, and all of that. And it looks as if that they have used all 10 steps that they have initiated. So you've done a great job. But in addition to that, what I'm getting out of there, and it somewhat gave me chill bumps, is that you went into this program because even though they're incarcerated, they're still people. And that really made a difference. I've learned a great deal from that. And I certainly appreciate you, Naomi, and PLC Partners for putting this on, and for the presenters. Thank you.
Thanks, Dorothy. Appreciate your kind words.
Thank you.
Thank you, Dorothy. One of the questions that came in with registration was what are the barriers that your state came across? So as the Medicaid entity, what barriers did you all come across as you were implementing this pilot?
I can speak to one of the barriers, and it kind of speaks to what Callie was talking about in the focus groups. We really wanted to be intentional about how we approach the next round of focus groups, and making sure that we compensate individuals that are participating within the focus group, regardless if they are a resident in a jail or prison or if they're in the community. So one of the challenges that we came across was, how do we do that? We as the state, we're not able to due to our current laws and regulations. So that's why it really did help having that discussion with a representative from the Justice Initiatives, and then reviewing internally to see what our options were to make that happen. And so that's kind of how we ended up with contracting with a community-based organization in order for that to happen, because we really thought it was important that we're utilizing their information to help support the work that we're doing, and they should be compensated for that.
I'm coming off mute because I'm just interested in how Maine got to the funding for this. Is this a legislative issue and that brought this forth? I'll put this in context because in Minnesota I work with Stratus Health, and we work directly with our Minnesota Department of Health and medications for opioid use disorders, and we're trying to work with jails. So we're addressing it and coming at it at a different angle, but we want to bring in what you're doing so well is the social and the peer supports. So we're kind of coming at it as an opioid use disorder while the person is becoming incarcerated to get them started on, Suboxone or whatever it is in the jails so that they're not overdosing or suffering during jail incarceration or overdosing on their release. And so I love the social piece is what we're missing. And then what I'm asking is, what are you doing with the opioid use and or other substance uses as people enter into the system in Maine? And thank you for your work. It's amazing.
I can talk a little bit about the funding and the substance use treatment piece of this. So, the pilot project, it was started by 9817 funds. So some of the ARPA dollars, this is a project that Loretta and Kelly have been leading using that initial funding. Then the state, our legislature passed a law requiring us to apply for the reentry waiver. And then after that, the federal government is requiring all states to implement the Consolidated Appropriations Act for juveniles, and they released a funding opportunity, a planning grant. And we applied for that planning grant in the first round back in November and were awarded the full $5 million, which we're really so grateful for. And that has led to be able to do more of this community engagement. Additionally, we're also in a unique position where our Department of Corrections leadership, really all of state government from our governor over the past 6 years, have been squarely focused on addressing the opioid crisis and overdose crisis in our state. And so our commissioner in the Department of Corrections require all jails and prisons to provide MAT. And so that is a requirement in every facility, and which is really amazing. It's obviously can be a little variable based on sheriff buy-in and resources, but it is a law that requires everyone to be offered. And so we are in a really unique position. Maine is leading the way on this, and our commissioners go and present at many conferences, and people get asked, "How are you doing this?" So MAT is medication-assisted treatment. So things like Suboxone, methadone, Sublocade to be able to treat opioid use disorder. And so I think, as Lisa's referring to, many people who are incarcerated, the rate of substance use disorders in Maine is very high. 60% of people have a substance use disorder who are incarcerated. And many people, when they enter, go into detox from the substances that they were using in the community. And so it's a really unique opportunity to offer someone treatment and help them move through into recovery and decrease the risk of overdose upon release. And then lastly, I just want to say, the incentive pilot, I know there was a question in the chat around requiring treatment, and certainly the incentive pilot did not require treatment at all, but it really, what it was doing was encouraging providers to connect. So whether that's the case manager, the outreach worker, to really provide that point of connection if that person wanted and was interested. So it was not requiring treatment. Callie, go ahead.
I also want to bring up the fact that some of our providers, so I oversee our opioid health home providers, they have contracts to go into the jails and prisons to be able to provide substance OUD treatment. And so we have uninsured funding because individual does not have main care while they're in there, except for emergency reasons. They use our uninsured funding, which will provides the payment to the provider for the services that they provide, and they have specific requirements of services that they have to provide under that model and the medication. So that is another way that individuals have been being able to get treatment and also connect to them. And in the opioid health home model, there is a peer recovery coach that's part of that model. So they're part of they're embedded within the jails and prisons as well. Not all of them, but a handful of our jails and prisons in the community.
I'm curious, Lisa, if you know how Minnesota has a reentry waiver, or they've applied. I'm not sure if it's been approved, but I'm curious if you know what their plans are.
I have not. I'm sitting on some of the MOUD, but we're directly working with jails and clinics. So
Okay.
I'm not directly working with the MDH, but we're funded through the MDH. So I'm not quite sure.
Okay. But I think that's another great opportunity, because if they are pursuing the reentry waiver, the waiver will provide funding. Covering medication for substance use disorders is required as part of the reentry waiver. So that will provide Medicaid funding for that treatment.
Oh, yes. Thank you. Minnesota Department of Health and medication assisted treatment. Sorry, we're using acronyms.
No, thank you. When there are things that I don't know, I'm always willing to ask, and knowing that that's part of too when you are engaging your individuals with lived experience too. So this has been fabulous. Are there any additional questions?
Yeah, Naomi, this is Libby. I had a question too. A great presentation, a phenomenal program, serving a vulnerable population that just we don't talk about a whole bunch, other than I think the places that we've come across this population is really with regard to opioid use disorder and substance use disorder. And so being as proactive as your program is, I think is very exciting, and would love to see it replicated in other states, obviously. I'm curious about your providers, and you mentioned some of the barriers that they had, which seem very logistical in nature, kind of, unsure when people are getting out and on and that sort of thing. But I'm also just curious, are the majority of your providers, would you classify them more as rural communities, as more academic or large health systems? Is there a balance? And do you see any difference in the two kinds of providers in terms of how they're approaching these programs with you?
Go ahead, Callie. I saw you come off mute.
Oh, that's okay. I would say it's a variety of
Okay.
providers. I will say sometimes our larger healthcare systems are part of like primary care practices and stuff. They do things a little bit different, and not in a bad way, but they don't come from the point of needing like comprehensive assessments and treatment plans and all of that. So it's really a learning curve for them sometimes. But
Okay.
we do have those providers that are part of this. They are part of providing the treatment. And that's for mental health and substance use, but for
Mhm.
primary care, yes, they are connected. But I feel like it's a variety of our providers, and some of them are very small, rural settings, and some of them are larger hospital systems. But I'll let Courtney and Loretta and Lisa Tuttle add to it if they have any more.
So I'd say there's some FQHCs that are really well engaged and partner well with county jails. We see a lot of our community-based mental health organizations really are often experts in this space that work really closely with the county jails. I see there's
Hmm.
lots of in-reach that happens. There are some organizations that are even doing intensive outpatient programs within the jails, and that way they're able to provide some seamless like continuum of care, which is incredible. But many of the jails they went, they all had like their partner that they work really well with. And most often it was a community-based mental health agency.
Gotcha.
We're also a CCBHC uh, pilot demonstration state, community certified community behavioral health centers, and that
Okay.
just launched this year. So starting in March, and then we have 3 programs that started, and then July. And with CCBHCs, they really are an integrated multidisciplinary team that can treat individuals struggling with both substance use and mental health, and they have crisis centers, and so they're really an incredible resource in our state. And so we have those geographically spread across the state in rural and urban areas.
Gotcha.
But I want to give a caveat. I think Maine's coming across really well, which I'm glad about. And we went through a decade of a divestment in mental health and public health under a previous administration, and then the current administration expanded Medicaid and has made historic investment in mental health and substance use treatment, and really squarely addressed. We were one of the worst states with overdose deaths, and so it has taken a whole state, whole system, public-private partnership to really make improvements. And we've seen massive gains in the past few years. So I don't want to paint it as if we've always done an amazing job. We haven't. We've really struggled for many, many years. But we've seen through sustained investment and engagement that we've made a lot of great progress.
Well, I think that was part of the point of my question, Courtney, was, you have set up some tremendous partnerships outside. Like one agency isn't just going to be able to do this. You're going to have
Okay.
to be good not only at engaging people with lived experience, but engaging the partners who can make policy change, the partners that can make practice change, the partners, And you talked a little bit about that in that you've gotten a lot of different clinicians, quite a diverse span of clinicians. And I just think it's important for us as we think about these larger initiatives to think about what the different audiences need, right? And what's going to bring them to the table beyond a passion for improving people's lives, because I really think that's a really big passion for a lot of people. I still believe that most people are in this business because they really do have that strong passion to improve people's lives. But we also have to make it functional for that organization or for that state program or, those local uh, practices and things. So I just appreciate that as you're talking, I'm thinking, oh, what would that agency need from this
Yep.
kind of a project? What would that agency need? And so it really is bringing that all together. Well done.
Thank you so much, main team. I'm going to start sharing my screen again. We are recording, and this will be on our YouTube page. Before you all leave us, we invite you to join us at the Putting Care at the Center conference. We will be facilitating a pre-conference workshop. The advisory councils transformed framework implementation. So as we talk about engaging people with lived experience, there's no wrong door, and that's what we're bringing to the table. So it doesn't just have to be a focus group or a listening session or an advisory council, but there are different ways to be able to engage individuals with lived experience. So we invite you to join us in Portland. Registration is open. Libby, is there anything else you'd like to share about that?
Yeah, that's okay. Thanks.
Okay. So again, thank you all for sharing your Friday with us. Thank you again, Main Care team, for being with us. I hope you all have a wonderful and a safe Friday. We'll see you next month. Bye all.